All right, we're back again in the month of April with another PEP procedural video here at the Miro Sim Center. Today we're going to talk about our percutaneous pneumothorax kit, which is the Wayne Cook percutaneous pneumothorax kit. I know that there's been some controversy lately about different kits, and some people may have been exposed to this kit and some people may not, so we wanted to go ahead and make a video because this is the only kit that we're going to stock from here on out. So thought we'd go ahead and make a educational video for people just to be familiar. If you are already familiar with this procedure, then excuse us for assuming, and just carry on with your day and how you would normally do it. If you're not, obviously, hopefully this helps. So the first thing is always to go over the equipment, and so this is what this is. This is what the kit looks like. The Wayne pneumothorax tray. It is a 14 French pigtail catheter. This is a percutaneous Seldinger technique kit, similar. And when I say Seldinger technique, as we all know from central line insertions. It is designed for pure pneumothoraces, not for hemopneumothoraces or for trauma. This is for your spontaneous pneumothorax in a young, otherwise healthy person, or potentially for like that bleb rupture in a geriatric COPD patient, etc. So without further ado, we're going to go through the kit and then show you the parts. Then we have our trauma sim man here today, and so we can go through a modified version of this procedure step by step. Obviously, you'd be in the ER or trauma bay, or not trauma bay, resuscitation bay, doing this procedure, and you would have full access to proper PPE and sterile equipment. We're going to kind of assume today that we all are in appropriate PPE and sterilized gown, hat, gloves, etc. And without further ado, let's now look at the equipment. We're just going to slide our trauma man down a little bit, and we're going to look at the actual kit. And this is what it looks like. Package insert, again, 14 French pigtail catheter here. So you would open your tray, and in a sterile fashion, obviously, you would open it. And this is essentially what you see when you open the tray. And we're going to go through these pieces individually here. All right. And obviously we have some gauze here. And in this tray here, we have a Heimlich valve, which is useful, for example, especially when sending the patient home. It allows obviously air to get out, but no air to come back in. And this gets attached to our catheter. It also can be attached to the atrium, or this connection can be used to attach to an atrium if you felt like you wanted to admit the patient. Other things in here, obviously, wire. We also have the catheter itself, which we'll go over last. And in here we have various things such as local anesthetic, a syringe to draw up the local anesthetic, 2 different size needles to administer anesthetic. We have 2 different sized introducer needles for our wire. One is a shorter needle, which you can see here, and the other one is a little bit longer, same caliber but just longer, okay, and a syringe for our introducer needle. Now, why do we have different sized needles? Well, essentially, as you probably already know, with a percutaneous catheter, there are 2 locations technically that you could put this catheter. Classically, mid-clavicular line, second intercostal space, where normally you would do a needle decompression, you could place a pigtail catheter, as you have a Turkle needle before maybe in the past, and it could be placed here. Alternately, and in my opinion, the better location would be in the mid-axillary line near the fourth intercostal space, similar to where you would put a trauma chest tube. It's usually more reliable. It's a little less cumbersome for you and for the patient also after the catheter is in. It's a little bit more comfortable for them and a little bit more aesthetically pleasing. We also have a scalpel. We have suture to secure the tube, and of course there is a dilator in here as well in true Seldinger fashion. So let's quickly look at the catheter itself. Again, 14 French pigtail catheter. The way this kit comes assembled, it does have a dilator or a straightener is what I like to use it basically, because truly the pigtail comes when the dilator or obturator is removed, and it may come actually disassembled, but usually should come in this put together case, or I should say it should come together in one piece when you open the kit normally. If not, the easiest way to do that is to make sure that the three-way stopcock here is pointing in the off direction to your auxiliary port here. That should allow you to go ahead and place the obturator back inside the catheter, which allows you then to straighten the catheter. This makes it easier for Seldinger placement. There are some markings here which do allow you to basically guesstimate where you are when you're placing this catheter. And of course there are about 5 holes here at the distal area, and you obviously at the very minimum would like to get the catheter placed to the first main black line. That would assure that all holes are inside the patient. But as we know, with larger patients, it's going to be at least the third black line that you would like to get inside the skin or subcutaneous tissue to assure that you have proper placement. And so personally, I like to at least place the catheter up into the thorax and into the patient beyond the third line here. Everybody's going to be a little different, obviously, if you have a very small, skinny patient or a very large, unfortunately, obese patient. Okay, so we now have our kit. This auxiliary port is nice as it allows you to potentially, once the catheter is inside the patient, it allows you to adjust, to do micro adjustments where, say you would like to actually withdraw air, which you can do with this kit. If you get a large enough syringe, like a 30 or a 60 cc syringe, you could adjust this three-way stopcock using this auxiliary port, attach a syringe, and then you could pull off air. And some of us who've been taught that procedure before have done this and will continue to do that. I like to do that initially, as I feel if it's a fairly large pneumothorax, you can pull off several syringefuls of air, and eventually it will become harder for you to pull that air off. And then at that point, I like to go ahead and disconnect the syringe, replace the cap, and turn that off. Now, you can connect, obviously, your Heimlich valve, which allows the patient to spontaneously breathe and go home if necessary. Some people will advocate for connecting to the atrium first and using a standard atrium setup, suction, and then will admit the patient and then do a scaled procedure where they go from atrium and wall suction to a Heimlich valve for a day or so, and if still tolerating this, then we'll go home after that. What you don't want to do is normally hook this up directly to wall suction, so you would like to at least use an atrium if you're going to plan on doing that. Okay, In the next part of this video, the next segment here, we're going to go over on the Trauma Man just a modified look at how this procedure would go. And then from there, hopefully gives you the idea of familiarity with the kit, how the pieces come together, and a quick overview of what the procedure would generally look like. Obviously, it would look somewhat different under sterile conditions, and we'll do our best to replicate. So welcome back. We're back on in part 2 of our Wayne Cook percutaneous pneumothorax procedural video. We have our simulated patient here who's partially prepped, obviously, so that you can kind of see what we're doing. Obviously, the patient would be fully prepped in sterile drapes. We would have had a timeout. We would have had a consent. I would be in proper PPE and sterile gown, hat, mask, gloves, etc. Any assistants, nursing staff, techs, etc. would be equally prepped. We would have all of our equipment, atrium, wall suction, already established and prepared. But we're going to skip those kind of steps or assume those steps today. So for time's sake and for educational purposes, the patient would be sedated, preferably. Yes, you can do this procedure just with local. It's personally my opinion. I feel like this procedure is a little bit better tolerated with some mild conscious sedation, but you know, that's not for me to dictate at this point. We're going to assume at this point that the patient is either sedated or has had some pain medicine. And what we're going to do again now is open our kit and discard that portion of it. We're now going to open our kit and as mentioned before, the patient is prepped sterilely. We would imagine that this entire region from the clavicle and midclavicular region to the midaxillary region, from the second, actually really first, to the 5th intercostal spaces would be prepped and cleaned with a ChloraPrep, betadine, or your equivalent sterilization liquid, soap, what have you. And then, as mentioned before, you can place this catheter in the 2nd intercostal space. We're not going to do that in this procedural video. In this video, my preference would be to put it in the 4th intercostal space using the nipple line as a marker for the 4th and 5th intercostal space. And the sort of midclavicular towards axillary region here. There's the midclavicular, axillary region here. So this is our spot right here. So sometimes some people would mark that with a sterile pen. You could mark that with a syringe, or however you like to do that, or hopefully just know. And obviously, as you remember, you're going to hug the top of the rib as you want to avoid the vascular bundle. So step 1 is obviously to prepare your kit. We have our Heimlich valve. We have our guide wire. We have our various insertion needles. I'm going to use the longer needle because of where the area we're choosing, the midaxillary 4th intercostal space. So I would set that up just like you would in a central line. I like to use my little needle holder. I obviously have local anesthetic, which I would open, as well as a needle here, and they are these safety capped needles. So I would then use my local needle, and while before, obviously I would go ahead and anesthetize the skin, making a nice skin wheel of local anesthetic, perhaps in several spots, as I move up and down that intercostal space where I know I'm going to be working. And then after I've got the skin numbed, I might go ahead and advance a little deeper obviously numbing down to the pleura, as that area is quite painful and well innervated. And after I've placed some generous local, I may save some of the local to use at the end again. And now I have my patient anesthetized. This particular patient I chose to do some sedation on, so he's doing well. Okay, now into the meat of the procedure here. We have our dilator as well, which we'll put with our guide wire. Now, this first step's pretty important and sometimes is overlooked with percutaneous procedures, but the first step, really or not, is to make an incision, which seems counterintuitive because you have this insertion needle. But what we like to do is make a little incision in the skin, just enough to be able to break the skin and subcutaneous tissue so that we can use our needle to help get it directly down into the subcutaneous tissues rather than going straight through the skin. Now, once we've done that, we're going to take our introducer needle and we're going to have our guide wire close by. Now, what we're going to use is, with the bevel up, we're now going to insert our needle into the patient, obviously hugging the top of the rib. We're going to insert, and basically we're going to retract and pull back with negative pressure in our syringe. Now, there are a few various techniques to this. Some people like to fill their syringe with a little bit of saline prior to inserting this needle so that when they enter the pleural cavity and with negative pressure, they do see some bubbling in the saline, and that's perfectly acceptable. I've done that before, and I like that technique. Or as you advance into the pleural cavity, you'll keep advancing until suddenly you feel a give on the syringe, and now the syringe just widely opens. Right there, I felt it, and I know I'm in the proper space at that time. So now that we know that we're in the pleural cavity, the next step, of course, this is a Seldinger technique, is we're going to remove our syringe and cover our obviously our needle here. We're then going to take our guide wire and we're going to insert the guide wire into the actual needle ourselves here, and we're going to thread our wire in until we feel like we have a good portion of the wire in. And once we've done that, holding the wire and the needle, we're going to negatively remove the needle and discard that, obviously, into some sort of appropriate container. At that point, we feel pretty good so far, and this is basic Seldinger technique. This is something that everybody has done before, I'm sure. And we're going to go ahead and thread our dilator. And we're going to use our scalpel again, as now we need to make a bigger hole in our patient just because of the dilator. And as you remember, like, hold the wire, the dilator does take some force, not too much. We've got our dilator in there. Again, be prepared for blood and other things to return. I'm just going to back that dilator right out. Discard that for now. Maybe cover the area. And now it's time to actually, use our catheter, which, just like a central line catheter, we're going to go ahead and insert through the actual catheter. And just like we would in the central line, we're looking for the wire to come out the center port or obturator here. And it's very important that you have the stopcock obviously not turned to the off position facing out. Otherwise, or turned slightly, that will impede the wire coming through the obturator. It's pretty hard to actually to thread the wire with the, or excuse me, to turn the stopcock with the obturator already in, so that shouldn't be a problem. But as we continue to negatively pass back our wire through the actual catheter, keeping control of our environment, you'll start to see the wire remove. And once I feel like I have a decent amount of wire, I go ahead and hold the wire and I follow the procedure I would with anything else. Now, it's important, as you can see, I still have a hole exposed here. My patient is fairly thin, so I'm going to at least push this catheter into the third black line. Some people, like I said myself, I like to advance a little bit further. It makes me feel better that I'm in. And then, of course, just like anything else, I'm going to go ahead and pull out my wire now. Okay, maybe covering that hole here. Next step would be to go ahead and remove the obturator. And as you remember, we did that before, and that's what really keeps that J-hook or pigtail in. And what I'm going to do at this point is go ahead and switch the stopcock to off to the outside area. Now I have my catheter fairly safe. I might go ahead and take my suture, and I would open my suture, which in this case is just a silk suture, and I'd grab my needle driver, and I would go ahead and secure this using some sort of a figure 8 or a purse string suture. And at that point, once I felt like the tube was secure, you could use appropriate tubing to connect your catheter to the atrium. In this case, it was a moderate pneumothorax, and what I think is reasonable at this point is to go ahead and connect the Heimlich valve. And what I would then do at this point, let me just move these pieces here so we can see a little bit more clearly, is I might choose at this point to then go ahead and open this port, auxiliary port here, and attach a 60 cc syringe. You'll have to imagine we have a 60 cc syringe here, but a large syringe. And then I might go ahead and pull several hundred cc's or mLs of air with my syringe. And then when I felt that that was satisfactory, or I met further, I guess I met resistance trying to pull off air, telling me that I've already extracted a lot of the pneumothorax air inside the cavity, I might go ahead and recap the stopcock. And then, of course, at this point, I would switch the stopcock back to the off position at the auxiliary port. And now, basically, the patient is breathing and air is escaping through my Heimlich valve, which you'll see as it flutters. The Heimlich valve, you'll see that little piece inside flutter. And when it does that, you'll notice that air is getting out, but air cannot get back in. So mimicking normal intrathoracic physiology. And at that point, since this is sutured, you may choose to use some sort of Vaseline gauze around the actual site itself. And then maybe you use some sort of 4x4 dressing to place, and some tape, and there you have it. We would have our successfully placed percutaneous pneumothorax catheter, and we will have drained the patient's pneumothorax. We'll get a chest x-ray, obviously, to confirm, and at that point, hopefully the patient is waking up, obviously, like feeling better, and then we can tell them that the procedure went well. Optionally, other people will tell you that at this point, before the patient wakes up and you've got your catheter in, if you have any lidocaine left over, it is reasonable to consider placing a little bit more lidocaine into that area around the catheter, obviously depositing the rest of your vial of lidocaine, because this is a painful procedure, as we all know, and it does help a little bit at the end to give some lasting anesthesia by giving some more local. At this point, this kind of concludes our procedural video for the Cook Percutaneous Pneumothorax Kit. I hope this was helpful. I think there's a few key things to remember. Obviously, sterile technique, number one, prepping and positioning your patient always is important. Number two, I think using the scalpel after anesthetizing the skin initially to make a track, a hole in the skin in the appropriate area before you try to use the insertion needle, before you try to insert the needle through that space. That way you're not dealing with a skin plug in your needle. Remember, if you'd like to use some saline in your syringe, that's completely up to you. Otherwise, as you advance negatively with constant negative pressure, eventually you'll have a significant release of negative pressure, which indicates you've entered the thoracic or pleuric cavity. At that point, it's just standard Seldinger technique, threading your wire, and then removal of the needle, and then going ahead and dilating, and then placing your catheter. Remember, when you place your catheter, you need to get all the holes inside the thoracic cavity. And so using those black lines, as mentioned before, which are helpful, in my opinion, at least getting a couple centimeters, maybe 3 centimeters or so beyond the third line seems reasonable. Securing your line, and then of course pulling out the obturator. Now, these kits do come with a Heimlich valve, which I think is actually useful. Remember, you can alternately connect this tubing to the atrium and then to wall suction, which I do not have at this point to illustrate. But those of you who are, obviously all of you who are familiar with standard chest tube placement, know how to connect to the atrium. So again, this is our new, I guess I should say, chosen solitary percutaneous kit that you will find now stocked in all of our ERs. And so take some time to familiarize yourself with the kit. Maybe take some time to watch the video to get familiar with some of the portions of the kit. Go ahead and watch the video and refresh yourself on the procedure. I think you'll find it's a very user-friendly system and a pretty straightforward procedure. Obviously, email, call, message with questions or comments or something that you do differently that you might like to add to these videos, because obviously there's a wealth of knowledge out there. So, but thanks for watching, and we'll be back probably next month with our third procedural installation, which should be covering paracentesis, thoracentesis with our new voted on kit. All right, so see you guys next month. Thanks.